Assalamu alaikum and good afternoon. Thank you, Dr. Vakar, for a nice introduction. This is my topic, and then I just go to the next thing. This is the outline of my talk. I will be discussing about the comorbidities and consequences associated with heart failure, and then I will be looking at some of the exacerbating factors, and then I'll look into the diagnostic challenges which we internists face across sometimes. And lastly, I'll just briefly touch upon the management with consideration of the clinical phenotypes. Now, the heart failure patients are generally admitted under care of cardiologists, but if they have got any acute medical problems or if they have got any associated comorbid conditions, they end up in being admitted under care of medical physicians or internists. Now, when they are admitted, we understand that when the diagnosis of heart failure is made, there's a period of clinical stability when their patients are remains asymptomatic and very well controlled on the medications. But then there comes a period of clinical instability when they require frequent hospitalization. And what I understand is that every hospitalization with congestive heart failure further decreases the baseline quality of the life and prognosis to the extent that patients becomes near terminal stage after some times, unless there is some cardiac transplantation facilities are available or a ventricular assist device are available. So when these heart failure patients are admitted, now this heart failure can occur at the time of the admission, or it can occur during the hospitalization when they are being admitted for under medical care for medical problems. Now, but we understand there are a lot of comorbidities associated with the heart failure, and then let us look at their contribution and the consequences of these comorbidities. Now, as we know that there's a large number of comorbidities associated with the heart failure patients, and majority of the heart failure patients will have at least 2 to 5 clinical comorbidities. And sometimes some of the patients may have 9 or 10 comorbidities. But the interesting figure is here that directly the prognosis as measured by the hospitalization rate and mortality rate is directly related to the number of the comorbidities which the patient might be having. So this is very important to understand. Now, when I'm talking about the outcome related to the hospitalization, now when outcome is if it is measured in terms of mortality or a prolonged hospitalization more than 4 days stays, higher the number of the comorbidities, more is the morbidity, more is the hospitalization duration, and of course, the less are the chances of patient will discharge home symptom-free. And there are certain other things which are very, very important. Apart from this increasing symptom burden in these cases and with the worst clinical outcomes, now treatment and management of these patients becomes very, very complicated, And the other thing is important, which I want to mention, is that these kind of this profile of the patients is sometimes or most of the times not included in common clinical trials. So whatever recommendations come from these clinical trials, it may be difficult to apply in these clinical scenarios in these patients. Now, let us just look at the common condition. One of the COPD is one of the commonest comorbidities, and about 40% of these patients may be having COPD. Now, we all know that dyspnea and edema can be more manifestations of both heart failure as well as COPD. And then it becomes challenge for the physician how much contribution of this dyspnea and edema is either related to the heart failure or is contributed by the COPD itself. Then we also know that when these COPD patients are admitted, they have got hyperinflated chest. So the common clinical signs which physicians rely, like S3, gallop rhythm or basal crepitations, may be obscured because of the hyperinflated chest or severe wheezing all over the chest. Okay. Similarly, if you rely on chest X-ray, may becomes less reliable because if the patient has got emphysema, then the increased CT ratio may not be there, and cardiomegaly may be masked in these patients. So in these patients, they also have a poor echo window. So this also makes our job very, very difficult, Then BNP itself can be high in COPD patients, So only ways to differentiate is the cardiopulmonary testing or cardiac MRI, but this is not available easily in the acutely hospitalized patients. This can be good for the outpatient setting, but in acute cases, perhaps this cannot be applicable. Then another problem is the treatment. Now, we always physicians are sometimes scared of using beta blockers and ACE inhibitors because we fear that maybe worsening the cardiac failure signs. But generally, it is recommended the cardio-selective beta blockers. They are quite safe in COPD. They do not exacerbate the respiratory symptoms. They do not reduce the FEV1, and they do not impair the response to inhaled bronchodilators, even in patients who have got a significant airflow obstructions. The sleep disorder problems, obstructive sleep apnea or obstructive sleep apnea, hypopnea syndrome, central sleep apnea with Cheyne-Stokes breathing, they are also quite common with congestive heart failure patients with two-fold increase in the mortality. Now, there are pathophysiological consequences of sleep-related disorders. Are these patients may develop hypertension and left ventricular hypertrophy per se, and then they may impair the cardiac function, including the systolic as well as the diastolic function. Plus, it could cause increases the oxidative stress and it can impair the endothelial dysfunctions. Now, the another thing is the symptoms related to the OSA, like daytime somnolence, impaired concentrations, and irritability, may compound the already patients, those who have got a low output failure symptoms like fatigue, tiredness, and listlessness. So it will be difficult to attribute which symptom is caused by the heart failure or by the OSA. Now, anyhow, whatever the things is, but CPAP is supposed to be improving these symptoms in both kind of the patients. Now, CKD is another very common, clinical conditions. About 40% of the patients of CHF may have a decreased GFR. Now, again, this, let's say CKD and CHF, again presents a diagnostic and therapeutic challenge because CKD itself is an independent risk factor. Or poor risk factors are predictor for a poor outcome in patients as far as the death is considered, or as well as the hospitalization with heart failure. Now, why? Because CKD, we all know it causes accelerated atherosclerosis, fluid retention, hypertension, anemia, and then they directly also affect the outcome of the congestive heart failure patients. And then on the top of it, the hypertension and diabetes, which are risk factors for both of these diseases, CHF as well as the CKD. So therefore, again, it will be difficult for a physician to differentiate which is due to heart failure or which one symptoms and signs are due to the CKD itself. But and there's another challenge is that, okay, we have to see, is this kidney damage or the acute kidney injury, is it caused by the congestive heart failure, or the this kidney failure is caused by the cardiorenal syndrome itself? So it's very, very difficult to differentiate in these conditions. Now, again, BNP, sometimes we rely on the BNP, but BNP alone can be increased in CKD patients. Similarly, fluid signs can occur in both CKD. The another problem in CKD patients is they are very resistant to the diuretics. And then when we are talking of the medications, we know that digoxin, although we are not commonly used by the heart for heart failure patients, but sometimes it increases the toxicity. Can I have just water, please? Water. Anyhow, so toxicity. The other thing is the role of ACE inhibitors, ARBs, in heart failure patients. Now, we are again sometimes hesitant to increase to start these patients with AC or ARBs, but sometimes because they may cause the electrolyte hyperkalemia. We are worried about these things, and or they may cause hypovolemia. Again, CHF with mild renal impairment, spironolactone is another drug. So we are sometimes scared to use it, although small doses of spironolactone can be used in patients with reduced kidney functions, but of course, you need to monitor the electrolytes and the kidney function very regularly. And whenever there's further deterioration, you have to stop this spironolactone. And beta blockers also, we all know they can reduce mortality and morbidity, and this benefit also occurs in patients having CKD as well. So therefore, you can still continue with beta blockers in these patients. Now, liver disease again has got ascites, edema, lower limb edema. Sometimes it will be, missed as presenting as a congestive heart failure, but you have to differentiate. Of course, JVP may not be elevated in cirrhosis, but again, you have to think sometimes cirrhosis itself can be a consequence of a long-term chronic congestive heart failure, what we call as a cardiac cirrhosis. Anemia was discussed slightly in the morning meeting. Just I want to very briefly touch on that. Anemia is very common in heart failure patients with multifactor etiology. It is also causes poor quality of the life, increases the symptoms and adverse prognosis. And why does it cause? Because it may directly cause myocardial ischemia. It may cause increase in the intravascular volume, causing fluid overload, or it may activate the neurohumoral activation. Depression again is quite common in heart failure patients, especially more in hospitalized patients, 77% of these patients. And it is also independent risk factor for the mortality in these patients. SSRI can be used in patients, but perhaps tricyclic antidepressants should be avoided. Now, when they are coming to us, it is very important for a physician to see what are the exacerbating factors. In one of the studies was suggest these are the commonest risk factors, which were commonest causes of exacerbation. You can see that poor medication adherence was the topmost cause. Infections, renal insufficiency, renal failure, hypertension, and dysrhythmias, fluid intake, myocardial infarction. These are the common precipitating factors for heart failures, okay, including some of the other inappropriate medications like IV fluids and the withdrawal of the diuretics, like these things. Now, this is very important. Now, how does this acute heart failure occurs? Now, acute heart failure may occur in patient who has previously undiagnosed without any underlying cardiac dysfunction, and the precipitating factors will make it heart failure. Or acute heart failure may arise as a de novo in a patient who was perfectly normal before, or a acute exacerbation of heart failure may occur in a patient who has got already chronic underlying heart condition with the addition of the precipitating factors. Now, there are certain compensatory mechanisms of heart failure. We all know cardiac compensation causes increased heart rate, increased cardiac contractility, cardiac dilatation may occur. There are sustained systemic compensation mechanism like increase in blood volume, redistribution, but more important, the neurohumoral compensation mechanism that includes the sympathetic nervous system activity, renin-angiotensin system, and atrial natriuretic peptide systems. Basically, heart failure is considered as a imbalance between so it is called a neurohumoral imbalance phenomena. Now, this is pneumonia is one of the commonest thing, and this will explain how does it affect heart failure. Now, pneumonia, by causing a systemic inflammatory response, it may cause acute kidney injury by impairing the electrolytes in water metabolism, and sometimes these patients they are being given IV fluids just to take care of the AKD, and this may cause volume overload. Now, systemic inflammatory response again may cause endothelial function dysfunction, which can cause peripheral vascular constriction, and again it will cause increase in the systemic vascular resistance, and that may cause congestion. It may also cause coronary ischemia, which can directly cause myocardial ischemia, and which can end up with cardiac arrhythmias, which may be the cause of the heart failure. Now, there's another way, hypoxemia. We all know it can again impair the cardiac dysfunction, which may lead to the sympathetic activation and because inflammation is a procoagulant state. So these are all risk factors for myocardial ischemia and myocardial damage. This all combination of these things, they end up patients developing acute heart failure in the setting of the pneumonia. Now, but I think, as I mentioned before, it's very important for us to determine, is it heart failure or not? So we all know there are signs and symptoms of left heart failure are quite different from the right heart failure. We all know the things. But and sometimes in these patients, we may not rely on the clinical parameters like JVP and heart sounds, and even the chest X-ray findings may not be classical because your patient may have COPD or pneumonia, which means this classical picture of pulmonary edema may not be appearing in the patients. Now, if you see there's a difference between hospitalized patients and the ambulatory patients, all the symptoms and signs of the congestive heart failure, they are much more common when the patients are hospitalized, including all the signs and symptoms. So it's very, very important to understand their things. There's exaggeration of all these symptoms and signs. Now, again, the reliable BNP may not be reliable because there are such a large list of a conditions where you can have a raised BNP, like even old age, ischemic, strokes, kidney failure, liver failure, sepsis, COPD, all may cause raised BNP. So BNP may not be the parameter which may be, deciding the heart failure. Now, this is another important thing. We all understand the classification, stages A, B, C, D. We all know the things, and we all know that heart failure can be divided according to the ejection fraction, normal or reduced or preserved, But the important thing is, I think this is one of the oldest classification, but I think very, very important for the clinicians. Here, the heart failure is divided according to the two parameters, where your patient is congested or not, and then your patient has got well perfused or not. If the congestion will be there, patient with pulmonary capillary weight pressure will be high, and perfusion is decided by the cardiac index. Now, these are 4 classifications. Warm and dry is a class 1. That means your patient will have warm extremities, adequate urine output, preserved renal function, and the lungs will be dry. In warm and wet, patient will have a warm extremities, but he will be congested. And congestion means there will be dyspnea, orthopnea, and lungs may show the basal crepitations. The cold and dry patients have, again, poor perfusion, oliguria, cool extremities, renal failure. Again, lungs will be clear. But in cold and wet patients, signs of hypoperfusion will be there and sign of congestion will be there. And these are the patients having the worst prognosis. What is the management outline? Again, management outline will depend upon these 4 classification. If your patient is warm and dry, no need to change any medication. You can escalate, or you can add some of the other disease modifying medication for these patients. If the patient is warm and wet, you may require to treat with the diuretics, and you may patient sometimes you have to remove the fluid overload by the renal replacement therapy. Cold and dry patient, again, these are the patients who will cut IV fluids more, nothing else. On the other hand, your patient is cold and wet, that is a difficult situation. This patient may require inotropic as well as the vasopressor agent. And of course, when there's a poor signs of poor perfusion, beta blockers has to be reduced or stopped. But if there's signs of congestion, you have to use the diuretics. Now, these are the 4 pillars of heart failure treatment, which are very must for all the patients. So beta blockers, angiotensin receptor blocker, and neprilysin inhibition, aldosterone. Now, these are the 3 drugs which can be titrated to the maximum doses, but SGLT2 inhibitors can be started without any titration. Of course, this is on the basis of a underlying other measures like diuretic therapy and the like monitoring the weight, decreasing alcohol, taking care of your salt intake in the diet. So these are the 4 pillars which are very must for the heart failure patients. Now, previously what we were doing is we were using all these 5 medications in a sequential voice. Step 1 ACE inhibitor, then beta blockers, then mineralocorticoid antagonists, then ARBs and neprilysin inhibitors, and lastly SGLT2 inhibitor. Now, this sequencing was lasting for 4 to 6 months. This was the outpatient based setting. But then there is now more and more trend is that to have a rapid sequencing of all these 4 medicines or 5 medicines, but you can use it within 4 weeks. But when it comes to the hospitalized patients, now latest recommendation suggests that you can even intensify the therapy by using all these 4 medications within before discharge. So 4 or 5 days, so you can titrate it off. It's very, very important to start these patients because these are the disease modifying agents which can affect long-term cardiovascular mortality as well. Now, these are the new medicine. I'm not going to touch on the thing. There are 2 medications which have been not yet approved by the FDA. Just look at this. Is one is Vericogot, that is a vasodilator. It affects the cyclic GMP enzymes, causing the local release of nitric oxide. And another one is the omecaptive, again, which is not approved by the FDA, and it is a this drug acts on the actin myosin component of the myocardium, so it affects the contractility of the heart. Now, there are different classifications. Now, I will leave it to my cardiology colleague to decide which medicines to be used or not to be used. But again, just for the awareness that these medications can be used. The red is, of course, red things you need to avoid it, and green and yellow things, perhaps you can keep on continuing with your patient. And then again, as I mentioned, clinical prototype is very, very important for these patients. Now, again, evaporating has to be avoided, but if the heart rate is, an atrial fibrillation patient, of course, evaporating cannot be given, but most of the other medicines can be used. But what I want to say is it's very, very important that for a physician to decide what is the clinical phenotype of your patient. But do not forget that these patients, they require optimization of the other therapy. So you have to maximize the treatment for hypertension. You have to maximize the treatment for the diabetes. And some of these patients may require anticoagulation. If the patient requires cardiac intervention like PCI or any, surgical cardiac implantation, something, or a treatment for atrial fibrillation, it is very, very important to take care of this cardiac component as well. Now, 7 protocols have just for a reminding. So we need to 7P. You have to remember, you need to decide about the phenotype, personality, medication, precipitants. You have to look for the precipitant factors. What is the pathology? What are the polymorbidity cases? And what are the potential iatrogenic harms from your medications? And lastly, patient preference is very, very important. No, so now its conclusion that heart failure is common in hospitalized medical patients with multiple comorbidities. It may pose a diagnostic and therapeutic challenge to the treating internist. A thorough evaluation is very, very important to ensure there's no potentially reversible factors or morbidities are there, okay? And another thing is that the in-hospital environment, you can take it as a positive way that in-hospital environment presents an ideal opportunity and the time to address and optimize these clinical morbidities. So therefore, a multifaceted, a multidisciplinary team-based approach is required for appropriate management of these cases. When I'm talking about the multidisciplinary approach, sometimes you have to require a care of the nephrologist or a diabetologist, a geriatrician, a chest physician, or a clinical pharmacologist, or anything. I think I ended in time. So thank you very much. Yeah.
Thank you so much.